great to have you online and interview you, Dr. Derek Mahony. You are a big name internationally and in Australia, and you've done a lot for dentists and the orthodontic industry in particular. And I'm honoured to have you on board tonight and interview you and up and close and personal, and love to get your feedback and pretty much what you have in terms of a message for the dental community tonight. Your background, Derek, tell me a little bit about how you started in the industry, and you know, you're an orthodontist, we all know that. You've got a lot of experience, and you've been quite a bit of an innovator out there. You're always moving forward. You're not complacent. You're always pushing the boundaries. You know, where is your background? Where does this drive come from? Why push the boundaries?
Well, I know I've always, I actually didn't enjoy dental school that much. And I kind of did dentistry to keep my parents happy. And the day I graduated, I think I got my degree, gave it to my dad and said, "Look, here, this is for you." And I took a year off and traveled around the world, right? Just by coincidence, when I was traveling around the world, I met up with an orthodontist, and he had like the dream lifestyle, and doing high-end cosmetic stuff every day, no blood, no needles, everyone was happy. It was in America. He had like a harem working for him, and I thought, man, this is the life, right? So I came back to Australia, and I said, look, I've got to get into ortho school. So I did the minimum time I had to as a general dentist to apply, and I knew I wanted to train in London because that was one of the first courses in the world that was actually offering what is now called straight wire. So, you know, pre-adjusted brackets and less sort of wire bending than what the traditional type programs were still doing. So, yeah, so that's where I started, and I've loved it ever since. I was never a good dentist, I might add. I think I did one root canal.
You're a better orthodontist than a dentist?
Yeah. I think I did one root canal in my illustrious career and created a few extra canals, right? You know, so yeah, just dentistry just didn't gel with me. And unfortunately, in the 5 years in dental school, you know, we had like 2 lectures in orthodontics, and one of them was how to refer all your patients to an orthodontist, and the other one was if you tried to do your own orthodontics, you know, you'd burn in hell. It was that sort of sorry, you know, turn off that. It was that sort of thing. So of course, when you graduate, when most dentists graduate, what are they hungry for? They don't really want to learn perio. They probably have a good basic understanding of crown and bridge and veneers. But, you know, the 2 big things that I look at young graduates want to learn are implants and orthodontics, and the 2 go hand in hand. So when I tried to learn orthodontics as a general dentist, you know, there was really nothing around. It was just it was a turf war. That's what it was. It was a closed shop where unless you did a full 3-year, or back then 2-year master's degree, no one would even take you credibly. There was a few pockets of this, a few pockets of that. So I obviously did the full orthodontic program. I really enjoyed it, and I made the conscious decision that when I did graduate, I would want to share this knowledge with whoever wanted to learn, and I found that's worked well for me as a business model. You know, in friends in the community, it certainly hasn't worked well for me with my peers because you know, how can
Can I say you're not the most popular person with the right?
Don't you have to?
But in teaching, you are.
Yeah. Well, look, I always say to my students, you know, when I die, it'll probably be one of the biggest funerals in the dental community in Australia. Not because I'm hoping, because all my students will be generally sad and come to see me off. But I think really the majority of people there will be my specialist colleagues who are there to confirm I'm going 6 foot under. I've no doubt about that, right? Yeah.
Look, your philosophy of orthodontics, you stuck it out in doing ortho for how long before you started to branch off into teaching dentists? How long were you practicing as an orthodontist?
I was in practice 6 years. and I was getting a lot of dentists knocking on my door. You know, as a new graduate orthodontist, I think I did two things differently. Number one, I didn't buy anyone else's practice because I worked for a couple of people and I just didn't. It wasn't that mentality that I saw with this American guy that I wanted to recreate. And number two, I didn't graduate in a local orthodontic program. So back then, that was two big black marks against what, you know, when I graduated, everyone would graduate. By the time they graduated, they'd already be working part-time for one of the big mafioso firms. And then the deal was they'd buy into that firm. And that's the way it was. You know? I started knocking on doors and I said, listen, I'm new. I graduated overseas. I have a philosophy that might be a bit different. I want to see kids early. I want to see kids between 7 and 9. And many of the dentists sort of said, oh my God, we've been waiting for someone like you, because when we sent kids at that age, we get a letter back saying, monitor, too young, wait till permanent dentition. So really, I found a niche that the dental community wanted, but it didn't seem as though the specialist community was offering it. Now, things have changed. I mean, you know, fast track now, this is my 30th year. Last year was my 30th year in clinical practice. I find a lot of my colleagues are now embracing intervention, early treatment, you know, and I think that's a good thing. But, you know, like the grief I got when I did that 60 Minutes program, which was just really, you know, this is what I'm doing.
Talking about the 60 Minutes program, for people who don't know, it's about the extraction versus non-extraction of the laterals. Is that correct?
Mm-hmm. And it was just really looking at what changes may occur if you have to take teeth out in mild crowding cases. But the point now is, and where I put all my emphasis in teaching and the way I practice, is all about airway problems. I'm convinced after 30 years of doing this that most kids have dental crowding because their jaw's narrow, because they can't breathe properly. And, you know, so much research is supporting this. As you know, I'm just about to finish my PhD. I've looked at over 3,500 cases of kids referred to me for orthodontics, but we did something different. We did a sleep study for these kids. And what did we find? 90% of them had sleep disordered breathing. And if you look at the AAO, that's the big governing body in orthodontics, they've just come out this year with a white paper on sleep apnea and orthodontics. And it's you know, if anyone wants a copy of that, send me an email, happy to send it. Read it, because it's exactly talking about what I'm talking about, which is when you see that kid who's got the narrow palate, you know, no room for the teeth, they're a mouth breather, they've got a recessive lower jaw, you know, don't think genetics. Think, look, is this kid breathing properly? Ask the questions. Does your child snore at night? You know, how's your child's performance at school? You know, these are the things that I'm trying to push. So people who follow my philosophy, students who I've taught over the years, they appreciate they're getting a more holistic approach into orthodontics. Look, if all your education and marketing and way of doing business is on straightening teeth, you've got a shock coming, because Smile Direct Club is going to straighten everyone's teeth. I can tell you that right now.
It's quite interesting. We're going to get to that in a minute, and I'd love to hear your opinion on it. But obviously, you know, you're saying early intervention, look at other things other than braces. There are other corrective things that need to be done in children, especially in the area of breathing. Okay, it's a big area, and a lot of dentistry tends to ignore that a bit, I think, in children. And not diagnose it properly. But how prevalent is it? It's quite prevalent, you're saying, out there in the community.
Yeah. I mean, I work very closely with ear, nose, and throat doctors, and I have done that for years, you know, and they get it. I mean, they see kids all the time who have nasal obstruction due to allergies, due to adenoids and tonsils. And now that they are looking at the palate, they're realizing there's a high link between these kids and a narrow palate, right? So it's like chicken and egg. They might clear the plumbing for these kids, and they do that well. But if the kid still has the narrow jaw, they're still going to have a compromised airway. So they need people like us. I have so many, you know, very reputable ear, nose, and throat doctors who say, listen, we're looking for dentists to work with, but, you know, how come these dentists that I have don't do expansion of the jaw? So, I mean, from a medical point of view, people much highly trained than us understand the concept.
Well, then that's a good question. Why don't more dentists do expansions of the jaw? Why don't they do it?
Well, look, when I trained in dental school and orthodontic school, we were told that the only time you expand the jaw is if you have a crossbite with a functional shift, okay? And then we were told you expand it rapidly. Now, people who've done rapid expansion realize a lot of it relapses because you're overpowering the system. You're tipping teeth like that and they're moving. So maybe a lot of people have tried it and have been burnt and things have moved because they haven't done it properly. You know, my lifetime has been looking at different rates of expansion. And I can tell you now, we do a lot of expansion. We don't just do it for a crossbite. We do it for breathing. We do it for bedwetting. We do it for speech pathologists who need to improve the tongue positioning. And we do it slowly. And when you expand the palate slowly, the palate kind of, which is that shape, remodels down. So it helps the airway. So I think if you speak to my students over the years, you speak to, you know, I have many doctors who work for me. 4 of them have gone off and become specialists themselves. And they do the same treatment that they saw me doing when they work for me. And that is doing the expansion. But they do it the right way. They do it slowly. So that you don't, you know, if you understand expansion, the old way of doing expansion, you crack that suture till the kid got a massive diastema like Madonna, right? Yeah. The new way of expansion, you hardly see a diastema because bone's remodeling, and that's the way to go. It's more stable, it's more comfortable for the child. Yeah.
It's an interesting subject, and I don't know if it's controversial, but it is an interesting subject, and so obviously sounds like it's an area that one needs to look at and explore. And I guess that's probably why your philosophy is to educate the dentists. It's because the dentists do see, they're the front line, and they do see a lot of this, and they don't diagnose it. Yep. Why not refer this? Why encourage dentists to do this, you know, in their armory of all other dentistry that they do? Why is it important that they should be there hands-on in this area?
I think there's not enough specialists in Australia to actually keep up with the demand. And when I started teaching general dentists, there was one other program, and it was Progressive Orthodontic Seminars, POS. You know, There's still kind of in existence now. Have a look now. Last year, there's 14 programs to teach general dentist orthodontics, 14. So from 2 to 14. Does that answer your question? Well, why is everyone teaching orthodontics now? Even the ADA, they have their own program.
It's true. Yeah.
And, you know, the hard time I got for teaching general dentists from the powers that be, now they're doing it themselves. Well, that's great. Look, I believe everyone is entitled to knowledge, but look, when a parent brings a kid in, the first conversation they have with the dentist is what? It's not about whether the kid needs fissure sealants, you know. It's about the crowding. There's no doubt about it, right? It's a practice builder. And let me tell you this, over the years, I've polled all my students year after year, and I asked them, since you've done the originally 2-year program, now 3-year program, do you refer more patients to your specialist? And the answer is yes. So because they know what to look for. Correct. So in actual fact, it's not as though they're taking all the orthodontic work. They're not at all. They're doing orthodontic work. They're doing the cases they're capable of doing, but because they're seeing a lot more, they know what to refer. The referral that they give is a lot more than they used to. And they say that routinely. Like the standard story would be this. Look, I used to refer 20 patients a year to the local orthodontist. Now it's probably 50 or 60, but I'm doing maybe 50 or 60 myself. So do you see what I'm saying?
Yeah, no, it's true, because they're actually looking for more of the condition now, and they're obviously more focused in that area, and so they're picking it up and they're treating cases and referring cases, and they're referring perhaps more difficult cases. Now that brings me to this next question: when should a dentist recognize that they don't have the expertise for a certain thing in orthodontics, and they should refer to an orthodontist? At what point do they decide that?
We have select criteria: class 3 jaws, vertical growth, you know, all the difficult growth dysplasias. They're definitely for referral to the specialist. And I teach that in my programs, right? You know who the danger is? It's the dentist who does a 2-day course in orthodontics and then starts treating everything. right? That's where the problems arise.
And there are a few of those. And
There are.
everybody I'm speaking on behalf of the dentists as well. There are people in their own profession that do that, and they
Yes.
acknowledge that.
Yeah.
So that's perhaps the concern in the industry is, and it's in every industry. It's also in it's also in implants, and it's also in cosmetic dentistry, whatever. So, but let me allow you to finish. Where do you feel that they, where you were going on about it? So you were explaining where they should.
So if you're treating an adult, there's no growth. What you see is what you get. As long as you handle the periodontal condition, et cetera, et cetera. I mean, they're the cases that most dentists are doing. Children, that's a bit of a can of worms when you talk about where are they going to grow and how are they going to grow. And, so we teach how to predict early signs of the adverse facial growth, the class 3 jaws and the vertical growers, et cetera, et cetera. Now, if a dentist gets that education, they can take the records and say, right, this is not a case for me. The other thing I really encourage is like a preceptorship, where a young dentist, once they do the training, starts treating cases under supervision. And so they bring their case to a more senior doctor and say, hey, here's the records. What do you think? Because that senior doctor is going to pick up a lot more than they are. And, so I would say my students, probably it's an 80-20 mix. They keep 80% of their own ortho, they refer 20% out. But it's probably 20% more than they used to refer. Yeah, so there's no way a general dentist, in my view, can do every case themselves unless they have a full-time master's program. And let me tell you this, I don't think after a full 3-year program, a new orthodontist should do every case themselves. I can tell you that, right?
It depends on how many cases they do in with experience, correct?
Correct. And they might have not done much surgical cases even in their 3 years, so they'll refer to a more senior orthodontist. So everyone learns, right? And I just think, look, let's be honest. If you do an endo and it goes wrong, the endodontists are not going to kick down your door or ring up the General Dental Council and Dental Board and say, look, this guy's done something he shouldn't do. Not at all. They're there to help you. If you try and tackle a wisdom tooth that's probably a little bit dicey and you crack the root and you ring your oral surgeon, he's there to help you. What is it about ortho that if something goes wrong, the poor guy gets crucified? What tell me about that. Yeah. That's not just me speaking. You want to do a poll for all your general dental audience and ask them, those who do ortho, I'm saying. Look, I'm not trying to encourage animosity between groups, but I just feel that general dentists are entitled to orthodontics as part of their scope of practice, and there's enough work for everyone. So I really do feel that it's a part of a dentist's full education to learn about airway problems in children, how to stop thumb sucking, how to correct a crossbite early. Why not? Because that's what they come across with kids in their practice.
That's fair enough. Now, say a new dentist a new dentist to orthodontics who has learned a bit about orthodontics and has taken your course. What would you recommend, or how would you recommend to integrate orthodontics into the practice? What would be the step 1, 2, and 3 process to make it into a turnkey business that it actually will make it, viable in the practice? Because honestly speaking, when I look at the business of orthodontics, I kind of discourage it away in some ways by dentists because it is not a very profitable business to be incorporating into the practice. I would say refer out because, it's probably more it's easier for an orthodontist to do and it's probably more profitable. But I do get this question quite a bit from dentists. How do you incorporate it and make it viable in the practice? Do you have a formula for that?
Look, one of my very clever students about 10 years ago wrote a book because she found the integration of orthodontics into practice difficult. And to this day, I still use that book and recommend it. Her name is Dr. Radhika. And what she said, she came up with some really good points. She said, number one, keep your inventory low, because when you get into orthodontics, if you really want to do everything, you need to buy a lot of stuff. So she came up with ideas, rather than keep your own bracket, use a lab that does your indirect bonding, so they keep the inventory. She came up with ideas where, you'll never be able to focus on orthodontics if you do orthodontic patients in between your normal patients. Like you can't do crown and bridge, root canal, extraction, then let's put brackets on. You've got to focus on initially one afternoon just of ortho. That might grow into a day. And the way you know you're successful is all of a sudden your one day becomes 2 days. But it's ortho, so everyone's focused on ortho, and that works really well. So, I mean, I invite Radhika still to come to my program and do a lecture on towards the end when the guys are in their 3rd year, they've got these cases going, and they want to start, being profitable in orthodontics. And let me tell you, orthodontics is very profitable. It's probably the most profitable part of dentistry. I look at my overheads, brackets, wires, they're very low into what the market price is. So I would have to disagree that orthodontics is not profitable for a general dentist if he does it if he or she does it correctly with time management.
Yeah, does that include also clear aligners?
With clear aligners, the novelty is you just have a spare chair, you throw someone some aligners, they wear it and everything's hunky-dory. The reality is clear aligner therapy is as difficult biomechanically as fixed braces. You need to know what you're doing. You need to know how to get yourself out of trouble. I mean, if you really think that any software in the world can take crowded teeth, get them straight, and then morph it so that that will really what's happened in life, you're kidding yourself. I teach clear aligners in my program, but I teach it for cases that I know are predictable movements, and we have a parameter checklist for my doctors. You can't just say every case you do can be clear aligners. No way, So is clear aligners more profitable? Well, in the sense that if you pick the right cases, yes, your overheads are quite low in the sense of inventory. I mean, to put braces on, you need the special adhesives, you need the brackets, the wires. For clear aligners, the lab does most of it for you. But the question is, will you rely on the lab telling you what case you can start? Of course not. You need skill for that. So I mean, there's a lot of people out there. I'm trying to think of the guy in Melbourne, John Hagapoulos, I'm sorry if the name is wrong. He's got like a clear aligner study group where he's saying, listen, I don't care which clear aligner group you're with. We're here to learn as general dentists, and we want to teach tips that work with all aligners. Like, how do you extrude a tooth when things aren't working? You cut the aligner, you put a button, you put an elastic on. These are sort of things that dentists doing aligners need to learn, because unfortunately, the big players in the market, what's their certification program for an aligner? Like, take the dentist's pulse, and there you go. You can start submitting cases. So that's why I'm trying to look. Excuse me if it's something like Aorta or something. The group, you know which group I'm talking about? I
haven't heard of them, but
they're like a clear aligner. Blah blah blah. They had a big symposium last year, and they invited all the big players, and it was hugely popular because when I speak to a general dentist and I ask them, do you do ortho? The ones I ask always say yes. And then I question, well, define that. And I would say 80% the definition is clear aligners. They say, yes, we offer ortho, but they're doing clear aligners. So it is a huge market, but it's a market where you've got to understand that you need good orthodontic skill before you do clear aligners. It seems like the opposite's happening. People are getting into orthodontics with clear aligners. They get burnt. They realize that wasn't an aligner case, and then they want to learn how to do fixed braces. Did you see? So yeah. I'm all for these 2-day aligner courses. Why? As a business model, they put people into my program who get burnt. Right?
That's fair enough.
Yeah.
I've had this question from a couple of dentists when they're not doing orthodontics themselves and they're not too comfortable, but they employ a dentist who does orthodontics.
Yeah.
Where do you see the risk there when the dentist decides to leave?
Oh, big risk, because, and by the way, the Dental Act is very clear on this. If you start an ortho case, no matter where you leave, it's your responsibility to finish that patient. And I have had a lot of dentists who come back once every 6 weeks to a practice 3 hours away to finish the case. So it's legally, it's your responsibility if you start orthodontics to finish that case. Now, for me, I have numerous associates. So at the end of the day, if they leave, I've got other associates that finish. But if you're a practice owner and you have 4 or 5 chairs, you don't do any ortho, but some dentist says, look, I can do the ortho for you. you've got to have a very good employment contract and make that dentist aware, well, listen, that means every case you start, you need to finish, right? Now, my advice, if you're a big practice, there's lots of young orthodontists looking for work. So I'd be more comfortable to employ a young orthodontist a day a month to do your ortho. That would be my advice if you're from a business model. So say you have no intention of learning ortho, but you've got a super successful practice. Why not ask a specialist to come in and do ortho within your practice? You're giving them a guaranteed 1 day a week, 1 day a month. You know, that I think is a win-win for everyone.
Interesting model. It's an interesting model. And there are a few orthodontists out there looking for, you know, work. Yep. Okay. All right. What's your opinion on tongue tie?
Look, it exists, but something's gone crazy in the last 2 years where, I don't want to offend anyone, but you could almost do a lecture.
It might be, Eric, they might be listening.
Yeah.
So,
what about, I wouldn't want to do a lecture, tongue ties for fun and profit. How does that sound?
Yeah,
right?
That's fair enough.
There's certain criteria to see whether a kid needs a tongue tie. And I would recommend a guy called Dr. Zaghi, Z-A-G-H-I. He's got really good stuff on the internet. He runs a thing called the Breathe Institute. He can tell you exactly which kid would benefit from a lip and a tongue tie, right? And I think that there is a need for it, but probably there's too many unnecessary releases. How can I put that? We teach as part of our program. I encourage dentists to get involved using diode laser for the simple cases, but to do the proper cases, you know, it's a surgical technique. And so not getting too technical, but when you start looking at the tongue, most people only focus on the anterior tongue tie. Some tongues have posterior tongue tie. Right. And my role, when I put my sleep dentist hat on, they're the ones that really cause most of the apneic problems, right? So you can release the anterior part of the tongue, but the posterior is still tied. And there's certain criteria and tests you can do for that, right? Mm-hmm. But by and large, and I think dental council, you know, health insurers, anyone who looks at the numbers game would see a spark rise in the number of tongue and lip ties in the last 2 years. No doubt about that, right? Is it because we weren't diagnosing properly all this other time, or is it a bit of, you know, over-diagnosis? Where's the thing? I think look at the evidence-based literature and look at the kids who need it. Now, what I don't do, and I'm not saying not to do it, but there's no way in my right mind I would do a baby's lip or tongue tie as a dentist, okay? Now, that's just me talking. Maybe because I'm an orthodontist and I'm not used to, you know, uncooperative patients and bleeding, right? And look, there is a need for babies to get lip and tongue tie if they're not feeding, you know, but on referral from a pediatrician, on referral from lactation consultant, you know, I think if a dentist starts saying, look, bring your babies to me for their first, I mean, like, you know more dentists than I do. What age would a dentist encourage a first dental exam? It wouldn't be birth, would it?
Probably not. No.
No. Right. Well, so there you go. Right. It's a controversial area. I believe in it if it's done properly and it's diagnosed properly. But I also feel that it seems to be that everyone who's got a midline diastema probably needs a labial frenum. That's not true. Everyone who can't lift their tongue to the top of their mouth needs a lingual frenum. That's not true. You know. Let's look at what would be the consequences if you didn't release that lip or tongue tie. Those sorts of things.
Fair enough. Thank you. It was really well answered. I've got a couple of more questions here. I want to go into, we've already now gone into the past and into the present. Let's go into the future. And I see that the landscape of dentistry is changing quite dramatically now with technology especially. And technology brings down the price also for you know, dentistry for the patient, that benefits as well. And it can increase the profitability for dentists as well. But I see that there's a big change, a really big change happening, and very dramatic as well in orthodontics. Where do you feel orthodontics is going to go in, say, the next 10 years?
Are you talking about globally or in Australia?
Well, let's look at it in globally and Australia. I mean, whatever happens globally is going to probably happen in Australia as well. We kind of lag a little bit behind, but we do follow suit. Let's look at, say, for example, Smile Club.
Yep.
This big thing that I've seen in the US for quite a while was sort of
it's huge now in Australia. Huge in Australia.
Yeah, it's here in Australia. It's quite interesting what they're doing and how the follow-ups there. And you know, I know a couple of dentists who are using it on their own kids, and I've seen the whole program and how they follow up. They actually do make calls from the US and you know, follow through with the patient. And tell us a little bit where you see the future with things like this, like, you know, Smile Club, Invisalign or clear aligners, you know, in-house softwares now that are coming in for suck downs, and you can start producing your own aligners in-house. Where's the face? Where's orthodontics going? How's it going to be cracked open? What's going to
every year I go to 2 big meetings, and I haven't missed them for the last 20 years. You know, the AAO, American Orthodontic Society meeting, huge, biggest orthodontic meeting in the world. And then the European Orthodontic Society meeting. And then so what do I see year by year by year? Every company is producing their own aligner, all the big companies, right? What else do I see? Every trade booth is becoming more computer savvy. So the cost of resin printers has gone down like you wouldn't believe. The softwares that were initially only available to people like Invisalign and ClearCorrect, now they're commercially available, you know? It just depends on how much you want to go into it. But to me, here's the future, right? 10 years from now, a patient will come in, they'll sit in a chair, they'll get a 3D facial view and a 3D x-ray. That will go directly to create their e-model. It'll go to a lab that will reset the teeth, and literally a few days later, aligners will come back. If all your interest is in straightening teeth, okay? But aligners will not fix kids' airways. Aligners will not stop a kid sucking their thumb. Aligners won't stop the genetic growth of the class 3. So there's still a need for the other type of orthodontics. But I'm a businessman. I look at the profit of Align Technology. Last year, Align Technology's profit was double the other 3 big orthodontic companies combined. What does that tell you? Yeah. So the aligners are here to stay. I have good friends of mine who I train with as orthodontists. They've moved from 10% aligners to now 90% aligners in their practice. 2 of them, in fact, they're coming out to lecture in Australia, Diego Piedra and Ivan Malagong. Their practice is 100% a clear aligner. And they tackle all cases with it, but they have the experience to do that. And why do they say they want to go clear aligner? This is my mates talking to me. They said, Derek, you don't have the headaches of wires poking. You don't have brackets coming off, you know. And if things are not working, it's because the patient's not wearing the aligner. Whereas when you're an orthodontist and you're doing traditional orthodontics, there's a lot more pressure. There's a lot more external visits. So I can see where aligners are going to take over the straightening teeth market. But remember, there's 3 types of orthodontics, and type 1 is what's called myofunctional therapy, oral myology. Chris Farrell's done really well in Australia with his myo brace, for instance, right? So that's all getting the young kids who have poor posture, can't breathe through their nose, have a tongue thrust, have an overactive mentalis, all good for that. Then you have the second part of orthodontics, which I'm strong in, which is called dentofacial orthopedics, widening the jaws that are narrow, correcting the class 2 early, bringing the maxilla forward with a face mask. You've got to do that in a growing kid, and no computer company will do that for you. And then the last field is orthodontics, which is straightening teeth when all the adult teeth are up. That is going to be aligner territory. Even for me, I would be the last person, if you asked me 10 years ago, you know, where do you think would you be doing aligners on all your cases? I'd say, you kidding me, blah, blah, blah. Right now, I'm 50-50. So all my patients who've had orthopedics, who have crooked teeth or need what's called phase 2, 50% are aligners. And I would say, you said 10-year plan, I would say 10 years, it'd be 90% aligners.
So with that said then, Derek, where do you feel that traditional braces is going to sit? Where is it going to sit in this industry?
It's going to be a bit like your, 4.5-inch floppy disk that you used to put in your 486 computer. right? That's pretty much it, you know.
So there is no real place for it in the future, do you think? Or can aligners do everything?
Right now, aligners can't do everything, but geez, they can do a lot. And I'm big on what's called pre-aligner therapy. So in other words, the tough cases, what do? I tell the patient, listen, we're going to put a couple of clear brackets on with this thin wire that you don't see. And then once we've done the big movements, I'm going to swap to aligners, right? Now, if you have that approach, yes, aligners can actually do all of your cases when it comes to that. What are aligners not good at? Everyone will agree with this. Extrusion and intrusion of teeth, right? Severe rotations. So if you can sort that out with a bit of pre-aligner therapy, then yes, you can finish the case with aligners. And it's a win-win. I mean, you know how many times I've had a teenage boy who doesn't brush their teeth with the fixed braces? You know, it's so great having aligners in that regard, et cetera, et cetera. So yeah, look, future is aligner therapy. You know, one of the big dentists big orthodontists in Sydney, who's almost exclusive aligners, Theo Basie. He does beautiful work. He teaches, and I've had this discussion with him, and he wouldn't have dreamt that he'd be doing that many aligners now. But things have changed. And have you ever spoken to Mark Van Eelding with the whole artificial intelligence and the ability to remotely check if the aligners are working? Have you gone down that path?
Yep.
It's a French company run by orthodontists. It's called dental monitoring. Man, that's just amazing. You know, imagine not even having to get your patients in unless you need to, because you monitor them through a remote channel.
I think with some orthodontists, it makes their hair curl with this idea that they're not so hands-on with patients, and aligners also coming in full force. And as I said, the landscape's changing. Now, with that said, where do you think where orthodontists are going to be placed and dentists are going to be placed in the market space as well? So where do you think that's going to change? How is the future for those two specialty areas?
Well, ask Invisalign. They have more case starts with general dentists than orthodontists, no doubt about that. And when someone thinks aligners, they just Google Invisalign. They Google, straight teeth, no braces, blah, blah, blah. So at the end of the day, I don't think the public will make a conscious decision. Do I need to see an orthodontist for aligners? Do I need to see a general dentist? Or do I go to the local chemist where they can scan me and away we go? You know how many direct scanning booths there are popping up in shopping centers? So, orthodontists have been moaning for years, why are general dentists doing this? Okay. Now, general dentists are moaning, why are the public going direct? It's a bit like whitening. You know, whitening was a big craze. And now most of the whitening is done over the counter, white strips, etc. Same thing's going to happen with clear aligners. It's unfortunate, but what do you do?
It's a changing landscape. It'll all reposition in time, and I guess everyone will find their way. There are certainly things at the moment that orthodontists can do. There are certain things that dentists can do. There are certain things that wires can do and aligners. So everyone has their position in the market space. But as technology improves, obviously the landscape keeps changing, and the patient is the one that wins at the end of the day.
Yeah.
So with that, Derek, it was really nice talking to you tonight. I really enjoyed this experience. I hope you have too. What's the final message you want to give to your audience out there?
Think airway first, teeth last. There you go.
Thank you. Thank you very much for tonight.
Thanks, Noel. Nice to catch up. See you.
Nice to catch up.
Bye.
Bye.